Assalamualaikum everyone. I am Dr. Maria Mejan from Surgical C Ward Khyber Teaching Hospital. Today I am going to present a case of Mr. Z, who is a 67-year-old retired banker from Peshawar who presented to our OPD with complaints of pain in both legs on walking from the last 5 years and pain in both legs at rest from last 2 months. And blackish discoloration below the big toe and sole of foot for 1 month. According to patient, he was all well 5 years ago when he noticed pain in the calf area of legs while walking for a long time. Initially, he used to continue walking and the pain used to subside after resting few minutes, but it gradually progressed to becoming worse, being able to cover lesser distances with time and eventually to the current situation of rest pain from the last 2 months. Pain is continuous and aching and moderate in intensity. He describes it as 6 to 7 on a scale of 10, more at night and relieved only on medication. Pain aggravates when the patient gets when the legs get warmer in a blanket. Patient's sleep is disturbed because of the pain, and sometimes he is hanging his legs down the bed or even sleeps on a couch sitting back. He also complains of blackish discoloration below the big toe and sole, also has a blackish or purplish discoloration. It started 1 month back and gradually progressed to complete black patch below right big toe. Otherwise, he has no history of fever, swelling of legs, trauma, pain, or pallor on exposure to cold, redness or itching, or burning sensation around the skin of superficial veins. His systemic review is also unremarkable. The CNS shows he has no transient blackouts or loss of consciousness or any blurred vision. There's no current complaints of chest pain. He has occasionally a dry cough. There's no history of abdominal pain, no weakness or paresthesias in the upper limb, and genitourinary also unremarkable. In the past, he's a known hypertensive from the last 12 years and is on regular medication. He had an MI 6 years back, after which angiography was done and PCI and stenting was done as well. He underwent amputation of the left second toe 3 years back after having a minor trauma because he says that his toe turned black. The patient is also married and has 4 children, the youngest being 15 years old. He has no history of impotence. He used to be a smoker from a young age until around 6 years ago when he decided to quit smoking. And he used to smoke a pack of cigarettes per day for almost 30 years. He currently uses only Naswar occasionally. He is a non-alcoholic. He uses normal balanced diet. The bowel habits and micturition are normal. The sleep is disturbed due to lower limb pain. Regarding the drugs, he is using amlodipine and valsartan, 5/80 BD for his hypertension. He had used aspirin, clopidogrel, statins in the past, but currently is not using any other medication apart from over-the-counter medication for pain relief. There are no known allergies. He had used nicotine patches for smoking cessation in the past. Family history is significant for hypertension and stroke, as his father died of stroke. And socioeconomically, his status is satisfactory. General physical exam. So should I continue to the examination part?
No, stop here. We will discuss the presentation part of the patient's history. So the main complaint which brought him to the hospital this time was rest pain and some gangrenous patches on his foot. Is it true?
Yes, sir.
And but you did discuss about his previous history, that for the past 5 years he had history of claudication, and the claudication was initially for you did not mention about the claudication distance.
So initially he used to walk, cover long distances, but gradually it declined.
Can you quantify the long distance? I mean, it was more than 200 yards or less than meters or less than that?
Initially it was more than 200 meters, then it gradually declined. The distance
declined to how much?
To the current rest pain. Now it is
okay.
We have rest pain.
Okay, and the journey from claudication to rest pain, how much time did it take?
So from 5 years to the last 2 months or so, 4 years and 10 months
More than
around
4.5 years.
and
Okay,
4 years.
he did complain of pain in his leg. What type of pain was it? What was the nature of the pain?
It was moderate to severe in nature and aching pain, um, and it was continuous, and it used to get relieved while he hanged his leg down due to gravity.
Okay, did this pain preceded by some other symptoms like in the form of pins and needle sensation in the skin and paresthesia, crawling sensation like that?
So as it was rest pain, so it was present almost all of the time. Initially, he used to have this paresthesia sensation.
Initially means what? In the phase of claudication or when it turned to the
In the
rest pain?
phase of claudication. I
Okay, in the
didn't mention.
phase of claudication, he had the prodromal symptoms in the form of paresthesia and numbness, and then
Yes,
followed by rest pain. The rest pain was continuous pain or it was intermittent also?
it is continuous.
Continuous. And was the change of posture of the limb was of some help as far as the pain relief is concerned?
He mostly used to hold his limb, or he used to hang his limb down the bed, or used to sleep in a couch even.
Okay. So, and on the other hand, he had a previous history of cardiac illness, true?
Yes, sir. He had an
Hypertension.
MI.
Okay, he is a non-hypertensive,
Yes,
non-diabetic. Any
yes, sir.
history of hyperlipidemia?
No, sir.
Any other illness regarding CNS, CVS, or biliary tract?
No, sir.
Okay. When did it happen? I mean, the myocardial infarction.
The 6 years back, and PCI and stenting was done as well.
It was done. So what happened to that cardiac condition afterwards during the 6 months, 6 years time?
So during the so he initially used medication, as I mentioned, but later on he lost to follow up. He did not do his proper cardiac
I mean,
checkup.
he remained stabilized as far as the cardiac condition is concerned.
Yes,
He had some instability in his cardiac condition.
he has no current chest pain, and his cardiac condition is stable.
Okay, so you have to mention the whole 6 years tenure. I mean, he was stable to the extent that he had to quit the medication and there was no big issue with him.
Yes, sir.
True or false? Okay.
Yes, and the
And
systemic review is
did
also.
okay, right. And did you inquire about the symptoms related to his CVS other than the chest pain?
Yes, sir. I inquired about that in the regarding the congestive heart failure. I examined him basically,
No,
and
I'm not talking about examination. I'm talking about the history of congestive cardiac failure or any other complication associated with hypertension and myocardial infarction.
yes, sir, there was no general complaints of edema or swelling uh, or
Cough,
there was a mild cough though, but he
shortness
is
of
also
breath.
a smoker, so maybe it is because of that. There is no shortness of breath.
Okay, and any respiratory symptom?
Um, so only mild cough on off occasionally he has, but also he is an ex-smoker, so maybe it is because of that, and it could be due to cardiac condition, so he would need workup.
Okay, and you did say that he was not having any history of allergy in the
Yes,
form of atopia or any
yes,
other skin and pulmonary allergies. True?
yes, yes.
Okay. And he is continuously on medication for hypertension and cardiac condition for the past 6 years. Was there any change in the
He's
medication
not on
during this
cardiac.
period? Sorry?
So he had stopped his cardiac medication, but he is on. He stopped his cardiac medication, but he is on his
Okay,
antihypertensives.
antihypertensive. Uh, uh, is there any history of any other drug intake like arbutamine containing compounds? Did you
No,
inquire?
sir. He only used nicotine patches for smoking cessation.
Okay. And you didn't mention that he had a history of amputation to two of his toes?
One toe, the
One
second
toe.
toe.
And it was preceded by a minor trauma, it was a major trauma.
Minor, a
So
minor trauma.
what
Barely.
happened what happened after that?
And so his toe had turned black, according to him, and he had to go undergo amputation.
Is there any history which is suggestive of altered sensation in his feet and legs?
No, sir.
Okay. So any other question, Dr. Keshwar? I think we have also with us Professor Muzaffaruddin Sadiq.
Yes, sir.
Any other point you want to raise as far as the history is concerned?
Sir, I would like to add a few points, sir. First of all, sir, it's a well elaborated history. दो तीन चीज़ें सर मैं ऐड करना चाहूँगा. एक इन्होंने इंटरमिटेंट क्लॉडिकेशन तो आपने मेंशन कर दिया कि द पेशेंट इज हैविंग हिस्ट्री ऑफ इंटरमिटेंट क्लॉडिकेशन, बट इट शुड बी elaborated further because by definition it's the pain which occurs in the muscle group
Right.
beyond the area of arterial obstruction. तो आपने इसको क्लियर करना है कि इंटरमिटेंट क्लॉडिकेशन का पेन, द पेन स्टार्टेड इन द मसल ग्रुप्स स्पेशली. इट वाज नॉट इन द जॉइंट्स, इट वाज नॉट अ पेन इन द लोअर बैक व्हिच वाज रेडिएटिंग डाउन टू बोथ द legs. It was not in the metatarsals. It should be clearly defined. The pain was in the muscle groups, number one. And number two, I would like to add कि आपने जब ट्रामा की हिस्ट्री की बात की कि उसकी एम्पुटेशन हुई हुई है, तो उसको ज़रा थोड़ा सा एलाबोरेट करना है कि उस टाइम उसकी हीलिंग कैसी थी. हीलिंग प्रोलॉन्ग थी, हीलिंग क्विक हुई, क्योंकि उस टाइम भी इस्कीमिया तो पेशेंट को चल रहा था. तो डेफिनेटली उसको ज़रा थोड़ा सा मजीद क्लियर करना है आपने, क्योंकि अच्छा इंटरमिटेंट क्लॉडिकेशन में कुछ पेशेंट्स को न्यूरोजेनिक क्लॉडिकेशन भी होती है, जिसको स्पाइनल स्टीनोसिस है, जिसको शियाटिक नर्व कंप्रेशन है. तो न्यूरोजेनिक क्लॉडिकेशन शुड बी क्लियरली डिफरेंशिएटेड फ्रॉम वेस्कुलर क्लॉडिकेशन.
Right.
That's all, sir.
Very nice elaboration. Sir Muzaffar Saab. Okay, now you can continue.
Right, sir. So moving on to the general physical examination, patient was sitting back with legs hanging below the level of the bed. He was comfortable and cooperative, well oriented in time, place, and person. His nutritional status was poor as indicated by average or lean build, a BMI of 58 by 1.75 square, which equals to 18.9 kg per meter square, and pallor indicates that he was anemic. After taking informed consent, the patient was examined in a well-lit room in the presence of a male doctor as a chaperone. And the vital signs, he was vitally stable, although the character of the condition of the vessel.
Sorry, Dr. Mari, I would interrupt you. Can you take in Urdu the consent taken from such a patient for examination of vascular examination or lower limb examination?
Right, sir, I'll try. So, अस्सलाम वालेकुम, मेरा नाम डॉक्टर मारिया मीर जान है. मैं सर्जिकल सी वार्ड में डॉक्टर हूँ और जिसके ज़ेर इलाज आप हैं. और आज मैं आपका मुआयना करूँगी, जिसमें पहले आपको अपनी आपकी टांगों को एक्सपोज किया जाएगा और उसमें पहले देख के मुआयना करेंगे, फिर उसके बाद डिफरेंट पोजीशंस में उसको मूव करके भी मुआयना किया जाएगा. इस दौरान अगर आपको कोई भी मुश्किल पेश आए तो आप मुझे बता सकते हैं, या दर्द हो तो मैं उसी वक्त अपना मुआयना रोक सकती हूँ. कोई और आपका सवाल हो तो वो भी आप बता सकते हैं, फिर ताकि हम मुआयना अगर आपको कोई एतराज़ नहीं हो तो फिर हम अपना मुआयना कर सकते हैं.
Okay, and this you have to take care that you have to counsel the patient and educate the patient regarding exposure and examination, number one, and you have to reassure the patient that this act of examination will not hurt you, rather it will help. So repeatedly, if you got any insecurity or any problem, you can warn me there and then you can make me stop over there, right? And you have to be gentle and polite to the patient. Okay, go ahead.
Okay, so vitally, the patient was stable, having a pulse rate of 93 per minute, and it was regular, normal in volume and character. But the condition of the vessel wall was slightly thickened, and it could be rolled up. And there was no radial or radiofemoral delay. The respiratory rate was slightly more, 23 per minute. BP was 130 by 90. He is afebrile. The JVP is normal. There are no clinical evidence of clubbing, cyanosis, icterus edema, or generalized lymphadenopathy. The examination of lower limbs was done after socially acceptable exposure. On inspection in the standing position, there was wasting of muscles of the lower limb, loss of fat, alopecia, and shiny skin. There were dilated veins and brittle nails. No ulcer seen between the toes, although the heels had cracked skin. An amputated second toe was also observed, the base of which was blackish. Inspection on lying down revealed both limbs were pale with guttered veins. There was no edema, congestion, or skip lesions. Examination of the right foot revealed a black patch below the big toe on the big toe, and another blackish to purplish patch was noted on the sole of the right foot just beneath the toes. The left foot had amputated second toe, base of which was black and shriveled and non-tender. The sole was unremarkable. Then I carried out a few tests. The capillary refill was checked and it was delayed to 5 seconds. The Burgess test was done by lifting the patient's leg while he was in lying position. It showed guttering of veins and the Burgess angle was 20 degrees at which the limb turned pale. The capillary refill time was also checked by hanging the feet off the bed, and the limbs filled up slowly and eventually became congested, showing positive sunset foot sign. Venous refilling time was also prolonged, it was 8 seconds. On palpation, the temperature was relatively cold of both feet, and there was tenderness over both feet and right lower leg midway between the between the knee and foot. There was no tenderness along the course of major superficial veins, and no crepitus was noted. The limb girth was measured 3 inches above and below the knee, and it was equal. The black patch beneath the right big toe is 3 into 2 centimeter, tender, well demarcated margins, firm and shriveled up. Area around the patch is non-congested. The patch on the right sole beneath the toes is 4 into 5 centimeter and is tender, soft to firm, and has surrounding mild redness. Left second amputated toe base is gangrenous and has tender margins, the bone felt at the base. Then the palpation of the peripheral pulses was done. The dorsalis pedis and anterior tibial wasn't appreciated on both sides, and the popliteal pulse, posterior tibial and popliteal pulse could not be appreciated on the right side. The rest of the peripheral pulses were palpable. On auscultation, there was no bruit over the central or the peripheral pulses. Doppler examination of the pulses was also done, and an ABPI was calculated, which was found to be 0.38. Regarding the motor examination, the limbs had normal tone and power of muscles, although there was decreased muscle bulk. The reflexes, including ankle and knee jerk, was normal, and the plantars were downgoing. The sensory system was also intact, including crude, fine touch, pain, and temperature. There was no enlarged inguinal lymph nodes, and the upper limb examination was also unremarkable. The systemic examination, the cardiovascular system showed a heart rate of 63 per minute, normal rhythm, S1 plus S2 heart sounds, no added heart sounds, and murmur or gallop. And the respiratory system was also unremarkable. There was a normal vesicular breathing, and no added sounds, and no basal clefts. The abdomen was also soft and non-distended and scaphoid shaped, and there was no mass of visceromegaly, no groin or ventral hernia. The bowel sounds were normal, no bruit over the aortic or the renal area, and there was no ascites. The sensory and motor function of CNS was intact, and there was no spine tenderness. I'll summarize my case as a 67-year-old ex-banker from Peshawar, known hypertensive, ischemic heart disease patient, presented with pain in the lower limb while walking from the last 5 years that progressed to severity of rest pain more in the calf area from the last 2 months, which is continuous and moderate intensity and relieved by hanging the feet off the bed or after medications. He also developed blackish discoloration beneath the right big toe and a sole of the foot from the last 1 month. Family history is positive for ischemic heart disease. On general examination, he is a lean-built man, well-oriented and time-place person with BMI of 20 and that's 19 kg per meter square. He is anemic with a pulse of 93 per minute and regular, but the vessel wall is thickened and can be rolled up. He is vitally stable. Lower limb shows pallor and wasting of muscles, loss of fat, alopecia, shiny skin, dilated veins, brittle nails, guttering of veins, and a 20-degree Berger's angle. The capillary refill is also delayed to 5 seconds, and the capillary refilling time is prolonged to 20 seconds. Limbs became purplish, showing positive sunset sign. The temperature relatively cold of both feet and the right lower leg. Tenderness over both legs is present. The right foot shows black patch below the big toe, and which is 3 to 2 centimeter tender and well demarcated margins and shriveled up. Another blackish and purplish patch on the sole of right foot just beneath 4 into 5 centimeter and tender, soft to firm, and surrounding area is slightly reddish. The left second amputated toe is gangrenous and has tender margins and bone at the base. Peripheral pulses are positive up to popliteal on the left and femoral on the right. There is no bruit. ABPI is 0.38. Sorry, that's and motor and sensory system is intact. There is no lymphadenopathy, and the systemic examination is unremarkable. So my clinical diagnosis is the patient is a 67-year-old hypertensive ischemic heart disease, ex-chronic smoker with chronic lower limb arterial ischemic disease, probably at right saphenofemoral artery level, and left popliteal or tibial artery level due to long standing atherosclerosis and thrombosis. And
Okay.
these could be intentions.
All right.
Sir Zareen, am I allowed to comment on a few things?
Yeah, why not?
First of all, it was a well-elaborated examination, and I must appreciate it. I would like to add only a few points. Number one is, it has been mentioned that the patient has a poor nutritional status. So इसका हमें हिस्ट्री में नहीं पता चला कि प्योर न्यूट्रिशनल स्टेटस पेशेंट का क्यों है, उसका एनोरेक्सिया है या क्या वजह है, क्योंकि इसको हम कोरिलेट कर सकते हैं वेस्कुलर डिजीज के साथ कि पेशेंट को कोई मेजेंटेरिक वेस्कुलर डिजीज तो साथ में नहीं चल रही, बिकॉज इट्स अ पॉलीवेस्कुलर डिजीज. अगर मरीज लोअर लिम्ब इस्कीमिया के साथ है तो डेफिनेटली बाकी वेस्कुलर बेड्स में भी डिजीज चल रही होंगी. सो वी शुड क्लियरली इंक्वायर अबाउट पोस्ट प्रांडियल एब्डोमिनल पेन, दैट इज एब्डोमिनल एंजाइना. तो आपकी हिस्ट्री में आपने एक जगह मेंशन तो किया था कि एब्डोमिनल पेन नहीं है, लेकिन उसको क्लियरली आपने मेंशन करना है कि दिस इज पोस्ट प्रांडियल एब्डोमिनल पेन एंजाइना, जो कि तकरीबन 25 to 30 मिनट्स आफ्टर ईटिंग शुरू होता है. एक ही चीज. दूसरा सर जो मैंने ऐड करना है वो ये है कि आपने जनरल फिजिकल एग्जामिनेशन में अपर लिम्ब में एग्जामिनेशन तो की है, लेकिन बीपी आपने एक आर्म पे मेंशन किया है. तो जब भी वेस्कुलर की एग्जामिनेशन होती है तो आपने दोनों अपर लिम्स का बीपी मेंशन करना है, क्योंकि वही बात आ जाती है, इट्स अ पॉलीवेस्कुलर डिजीज, डिफरेंट वेस्कुलर बेड्स आर इन्वॉल्व्ड. अच्छा, तीसरा पॉइंट सर मेरा है, एग्जामिनेशन में आपने एब्डोमिनल एओर्टा के एग्जामिनेशन या पल्स मेंशन नहीं की, तो वो भी आपने मेंशन करनी है, क्योंकि आपके पेशेंट को तो चलो फेमोरोपोप्लीटियल डिजीज है, बट इट मे बी एओर्टोइलिक, पेशेंट का एओर्टिक पल्स ही नहीं फील हो रहा आपको और आगे नीचे जो है ना उसकी इस्कीमिया चल रहा है. सो abdominal examination में आपने मेंशन किया है, that's appreciated, but when where you are mentioning pulses तो आपने दोनों femoral popliteal उसके साथ ही abdominal pulse भी मेंशन करनी है. ठीक है. अच्छा, एक और चीज ये है कि जब ऑल बॉडी पल्सेस आप लोअर लिम्ब की पल्सेस आप मेंशन कर रही है तो बाकी बॉडी की पल्सेस भी कैटेगोरिकली मेंशन करनी है. सबक्लेवियन, एक्सिलरी, ब्रेकियल, रेडियल, अल्नर, all were present, absent or weak. Okay. प्लस ब्रूई का मेंशन करना बड़ा जरूरी है. जहां पे स्टीनोसिस होती है वहां पे ब्रूई आती है, तो आपने स्टेथ से फेमोरल एंड पॉप्लिटेल एरिया के ऊपर मेंशन करना है कि देयर वाज नो ब्रूई प्रेजेंट. और
That
लास्टली जो पॉइंट मेरा है वो है एंकल ब्रेकियल प्रेशर इंडेक्स का. वो आपने सिर्फ एक लेग का मेंशन किया है, और ये नहीं आपने मेंशन किया कि ये यूनिलेटरल है, बायलैटरल है. So your case is a patient of peripheral vascular disease. You have to mention ankle brachial pressure index of both lower limbs.
right, so the right separate and left. Yes.
ठीक है, मेंशन आपने दोनों का करना है, तभी हम कंपेयर कर सकते हैं. Over to Sarzarin, sir.
Okay, thank you very much, Dr. Keshwar, for your observation and nice presentation. Dr. Maria, you did mention about the examination of the affected and other limb also. And during your examination, you did find that this patient had was there a discrepancy in the length or limb or gut discrepancy on the both sides?
No, sir.
Just on
No,
inspection,
sir.
you did not find. And you did mention about alopecia. What does that signify?
The alopecia signifies the desquamation of the top layer of the skin, and due to poor blood supply, which is a feature of chronic limb ischemia.
So it's suggestive of chronic arterial occlusive disease. Okay, and you did mention about the guttering of veins.
Yes, sir.
What is capillary refill time?
Sir, in capillary refill time, we press the nail bed for around 5 seconds, and then we release it, and it should normally fill within 2 seconds. And if it's prolonged than 2 seconds, we say it's delayed.
It's delayed. It's suggestive of CAOD. What is capillary filling time?
In capillary filling time, we after it's
No, sorry. I mean, that was capillary refill time you described. I'm asking about capillary filling time.
Capillary filling time is the time that is taken for the limb to turn back pink after raising it.
Okay, I mean, you raise the limb, the color will turn from pink to pale, and then you put the limb in a dependent posture, and the time taken for the skin to become pinkish is known as capillary filling time. And what is the normal capillary filling time?
Less than 20 to 30 seconds.
Okay, and what is venous filling time?
In venous filling time, also we raise the limb and it is emptied, and the veins collapse, and then we bring the limb down, and it should normally fill within 5 seconds. And if it's prolonged, we say that it's
you did mention that okay, right, you did mention that the temperature on both sides were comparatively decreased. So where did you compare it with?
So with the normal temperature of the limb as well as the arm.
Okay. And how do you feel for the temperature?
By the dorsum of the hand. Because
why you are using dorsum of them? Why not the palm?
Because the skin of the dorsum is more sensitive to this temperature sensation.
Okay.
And also the palms are moist, and that would and sometimes they are give the false impression of moist.
So while performing the Burgess test, what was the vascular or the Burgess angle in your case?
It was 20 degree.
It was
20 degree.
20 degree. So you mean the color changed from pink to pale while raising the limb up to beyond 20 degrees? True?
Yes.
Right. Okay. Dr. Kishore told you about examination of all pulses in human body, all palpable pulses, and there's the mandatory examination, right? So
Yes,
and it's well said that pulses can only be palpated when you are pressing an artery against some hard surface like a bony structure. So while palpating the lower limb pulses, where exactly you have to palpate the dorsalis pedis, posterior tibial, popliteal, femoral, and others?
So if we start from the dorsalis pedis, that is usually felt at the in the proximal intermetatarsal area, just lateral to the extensor hellicis tendon, extensor hellicis longus tendon, and
Yes.
Then the posterior tibial artery, it is felt
I mean,
against
you are pressing the artery against which bony structure in dorsal pedis?
the navicular bone, the
Navicular
tarsal.
bone ahead of first metatarsal.
Yes, sir.
And posterior tibial?
Posterior tibial is against the calcaneum. It's just behind the medial malleolus. Some say midway between the medial malleolus and the Achilles.
Okay. And what bony structure is used here for palpation?
Or against the back of medial malleolus or calcaneum.
Calcaneum, right. Popliteal arteries, how do you feel for the popliteal pulse?
The popliteal pulse, for the popliteal pulse, various methods are used. One is that we flex the limb to 120 or 135 degree, and then we dip our fingers, stabilize our thumb on the tibial tuberosity, and dip our finger in to the popliteal fossa, and we feel it like that.
Is
And
it easily palpable? Is it easily palpable?
no, sir. An easily palpable popliteal pulse would create a suspicion of popliteal aneurysm. So it is not
Okay.
easily palpable.
Okay. And where do you feel for the femoral pulsation?
The femoral is at the just beneath the mid-inguinal point, that is from the anterior superior spine to the pubic symphysis. We draw a line, and midpoint, 2 to 3 centimeter below that, we feel it.
Which bony structure you are pressing the artery against in this case?
Against the neck of femur.
Okay. What is the method of palpating the lower limb pulses? I mean, you finish with one limb and then come to the other side, or you do it simultaneously?
Ideally, we should do it simultaneously. All the pulses should be done simultaneously, except for the carotid arteries, one at a time, because of vasovagal.
Okay. While feeling for the subclavian artery, where you feel for the pulse?
So it's against the first rib. It's in the middle of the supraclavicular fossa against the first rib.
And which bony structure you are pressing the axillary artery against?
So the first rib.
No, I mean axillary artery.
Axillary is against the humerus, the medial aspect of the neck of or shaft
Okay.
of humerus.
Okay, while examination of this CVS in this case, did you find any positive findings like?
So the lower pulses on the right till the popliteal artery were absent.
No, I mean cardiac examination.
Examination. No, so there wasn't any significant finding.
I mean, was there any sign of CCF? You did mention that the JVP was not raised. While
there was no added sound. The respiratory system revealed no basal crypts or effusion, and the abdomen showed no ascites or hepatomegaly. So there was no obvious sign of CCF.
Okay, right. Dr. Keshwar told you about the importance of bruit, listening for the bruit. So what is the basic mechanism of bruit and where you have to exactly auscultate it for?
So bruit is basically for the, it is created because of the turbulence of blood flow through a vessel because of some narrowing. It could be due to atherosclerosis or some stenosis in the vessel, and it is the various the same landmarks on which we palpate. We usually put our bell of the stethoscope over there to listen for the bruit.
Okay, the bruit can be palpated, can be auscultated at the nervous part, or proximal to that, or distal to that.
Sir, it is usually proximal to that stenosis.
I don't think so. I think it can be either auscultated at the point of nerving, and it can be palpated, listen to it distal to it also.
Yes.
Okay, where do you listen to the bruit for subclavian artery stenosis?
In the supraclavicular fossa.
For renal artery stenosis?
So it would be in the renal area, the flank area of the abdomen, just beneath the level of 12th rib.
Okay, from back side or front side?
This is from the back mostly.
And for the femoral artery or iliac arteries?
So femoral is the midway between anterior superior iliac spine and pubic symphysis.
Okay. So in your case, your ultimate diagnosis was peripheral arterial occlusive disease. And it's a chronic or acute one?
So it's a chronic one.
So what makes you think so? It's a chronic, it's not an acute one.
So various indications in the history, risk factors like he's a male and he's an old age, 67 years, long-standing history of hypertension, also a history of smoking. Family history is also positive for ischemic heart disease, and so
Uh,
the severity of
What,
the
what are the
binding.
specific points in the history of the patient?
So also the claudication history, and then it progressed slowly over 4.5 years to rest pain, and also the degree of changes in the gangrene is not so severe, so as to account for acute embolism. So it's
Okay,
most probably a
so
chronic process.
I mean, if a patient has got chronic arterial occlusive disease, what could be the different types of presentation?
The so I didn't get it. The levels of
I mean, possible presentation. I mean, how the patient can present to you with.
so you can present with claudication or can present with a gangrene or
So, right,
pre-gangrene ulcers.
the patient can have, the patient can either remain asymptomatic also,
Yes, sir.
or they can have mild symptom in the form of claudication. And if the disease progresses further, the patient can have presentation in the form of rest pain, pre-gangrene changes, or even gangrene formation, right? So
Right.
what is claudication basically?
The claudication is actually literally it means to limp, and derived from the Latin word claudicare, and Claudius was a Roman emperor who used to limp, and because he had polio, but still this name became popular. It's a claudication is basically when the person is walking and due to pain in the calf area, he is compelled to stop, and it improves with rest. The pain.
So is it important to have a pain-free journey before he or she develops pain, or the pain is there right from the beginning?
So there is a pain-free journey usually. At the start,
Okay,
and, he also develops thighs numbness, and gradually it becomes painful, and he has to rest, and then it becomes it
okay,
improves.
okay. What is claudication distance?
Claudication distance is that distance which the patient can walk pain-free.
Okay, and what are the factors which can decrease the claudication distance?
uh, that can decrease, and that includes increased pace of walking, like exercise or climbing uphill, or
Walking against the winds,
walking
right?
again.
Okay, nice. What are different types of claudication? Type 1, type 2, type 3. Do you know something about that?
So the grades,
Yeah, claudication has got 3 different types.
so one if types, they can be neurological claudication or um, vascular claudication or venous claudication. Are you talking about that?
Okay, yes. Yes, you are right. That is the different types of claudication, but I'm talking of the vascular claudication.
Yes, so the vascular claudication, they are divided into grades. There are different classification systems for that. Boyd's classification, which includes 4 grades. Number one is when the patient is patient's pain is relieved on continued walking, because the substance P, which and the metabolites, toxic metabolites, they are washed out. And grade two is when the patient continues to walk in spite of pain. He is able to tolerate that. Grade three is when he is compelled to take rest. And grade four is pain at rest.
Okay. What is the mechanism of pain in claudication?
The mechanism of pain is because of walking, the tissue demand of oxygen, it increases, and the vessels, as they are chronically obstructed, so the collaterals, they diet, and anaerobic metabolism is there, and the substance P is created, which basically causes the pain.
Right. Okay, in your case, you think that this patient has got chronic arterial occlusive disease and you have got different reasons for that. So can you exactly comment on the level of occlusion,
So
stenosis?
as the patient is having claudication of the calf area, so it's usually one level above that. So it's most probably the superficial femoral artery or the common femoral artery level.
Okay. And so he was denying history of any pain in the buttock or hip area or any kind of uh, mm, uh, uh, dysfunction, erectile dysfunction, right?
Yes, sir.
So if it happens, what's that called?
That is the
Pain, lyric
lyric.
syndrome. So, and what's the mechanism of lyric syndrome?
So basically, it includes the buttock aortoiliac occlusion, which leads to occlusion of the internal iliac artery as well, and
Yes.
that leads to impaired flow to the penis, and which leads to which leads to erectile dysfunction and impotence, together with buttock and thigh claudication and wasting of the muscles of the buttocks and thigh.
Right. So in your case, you think that this is basically occlusion at the femoral artery level. And what could be the most common reason for occlusion?
So the most common reason could be thrombosis, and upon that atherosclerosis, upon that thrombosis has occurred, or it could be an embolus as well.
Okay, right. And if suppose the major vessel is not involved, the minor vessels are involved in the chronic occlusive diseases, so then what other reasons can be made responsible for, apart
So
from atherosclerosis?
the other reasons could be thromboangiitis obliterans, or they could be diabetic foot, or different types of arthritis,
Yes. And
or uveitis.
yes, how you investigate this patient to confirm your diagnosis?
So the investigations would include the general investigations, including the workup for cardiac as well as the baseline tests.
The question is
And
that how you'll confirm your diagnosis.
so how okay, so the confirmation is basically by the angiogram, which is not usually done because it is invasive. Unless we are going to operate, we don't do that test.
How do
CT
you
and
start with? How do you start with in your routine examination?
examination.
I
Sorry,
mean,
investigation.
routine investigations.
So routinely, we first do different blood tests to check for anemia, diabetes, renal disease.
That's normal, but what confirmative investigations are done?
A Doppler is done usually, and then CT angiography or magnetic resonance angiography.
You did mention about the ABPI.
Yes, sir.
Although some people they would include it as a part of examination, and others would include it in the part of investigation also. So how do you perform ABPI?
So ABPI is checked on the bedside, and it's done by measuring the the highest systolic blood pressure at the ankle. So either the dorsalis pedis, the posterior tibial, or the common peroneal artery. The measures can be taken.
So
Whichever is
you have to record the pressure twice in the lower limbs because there are two arteries.
Yes, sir.
Right? True? False?
Um,
And then you take the
yes,
highest
sir.
value amongst that and you divide by a single value in the upper limb. Right? But as Dr. Keshwar has already told you that you have to do on both sides. One side is not sufficient.
For the right, we'll check the highest value among these three: the dorsalis pedis, posterior tibial, and common peroneal. And in the upper limb, whichever right or left brachial pressure, systolic pressure is highest, we'll take that as the denominator.
What's the
So,
significance of ABPI?
so it's significant because it tells us about the severity of the claudication, and it also helps us to decide if it's decreased, that it indicates that there is some flow limiting disease, and
Okay. And what's normal ABPI and what's abnormal one?
the normal is 0.9 to 1.3. And then if it's less than 0.9, there's some arterial obstruction or claudication. If it's less than 0.5 to more than 0.3, then it indicates rest pain, which is indicates critical limb ischemia. Less than 0.3 is imminent necrosis, and more than 1.3 is a sort of false reading, which can occur in calcified vessels,
Okay.
like incommunicable or diabetes
So,
or renal.
suppose you have recorded an ABPI and it was raised, it was 1.1. You made him exercise and it has raised to 1.3. What does it mean?
So if it has raised, then I think it's normal.
Okay. And you made him exercise, and after exercise, the ABPI has fallen to 1.8. Sorry, 0.8.
Then it indicates the occult disease, intermittent claudication, which has become unmasked due to
Okay.
exercise.
Right. So in normal people, after exercise, the ABPI rises, and people with CAOD, it decreases. True or false? What's the pitfall and limitation of ABPI?
So the limitation, I think, is that it sometimes cannot tell about the vessels that are calcified, like in diabetics or end-stage renal disease.
Okay.
Uh,
What's
they are not compressible.
You did mention about the Doppler study. What's the mechanism of Doppler study in vascular diseases?
So the Doppler is based on the flow of it tells us about the flow of blood through the vessels, but it does not tell about the anatomy of the vessel. Also it can tell about the direction of flow, and there are three waves in it.
Hello?
In the normal pattern, there are yes,
Hello?
sir. Yes, sir. Hello.
Uh,
Hello.
yeah, I think Dr. Zareen's internet got hanged, so you can continue with the ABPI.
We can listen. We can listen.
I was telling about the Doppler ultrasound, that it is based, it detects the moving blood, and usually we use the bedside handheld Doppler, and there are usually three waves in the normal state. One is the systolic wave, and the others two are diastolic waves. The first one indicates the vessel compliance, and the second diastolic indicates the forward flow of the blood. So if there is any abnormality, then it can become biphasic or monophasic.
Why does it become biphasic or monophasic?
When there is obstruction, or when there is some sort of obstruction, there is a reversal of flow, and then the biphasic pattern is there. And when there is complete obstruction, it will be monophasic.
And how about
Any relation to the breathing respiration cycle?
To the respiration cycle? Sir, I don't know.
Okay.
So can you please explain the changes with respiration in Doppler?
Sir?
Okay, Maria, how about the duplex ultrasound? What does duplex signify?
So the duplex is a combination of Doppler ultrasound with the B mode ultrasound. It can also tell about the anatomy of the vessels. So it is more accurate than Doppler ultrasound in detecting.
And is there any significance of color flow?
Yes, the color flow can tell us about the direction of flow as well.
Okay.
Regarding ABPI, which what requirements आपके पास क्या क्या चीजें होनी चाहिए ABPI measure करने के लिए?
ABPI के लिए we should have a Doppler probe and a sphygmomanometer.
Okay. Handheld Doppler होना चाहिए आपके पास. और ओके और अगर किसी पेशेंट का ABPI फाल्सली हाई आ रहा है,
Yes,
0.3 से लेट से ऊपर आ रहे हैं, उसकी रीजंस आपने बता दी कि कैल्सिफाइड वेसल्स है जो कि डायबिटिक्स में होती है, एंड स्टेज रीनल डिजीज में होती है या ग्रोइंग एज के साथ होती है. तो कैन यू मेंशन सम अदर टेस्ट्स के ABPI के बाद हम अगर लेट से ABPI हाई आ रहा है तो हम उसको कैसे मजीद क्वांटिफाई कर सकते हैं? किसी और जगह हम डॉपलर पल्स ले सकते हैं?
Yes, sir. इसमें फिर हम we can do toe pressure, which is more reliable.
Great. Toe pressure is important क्योंकि toes की जो vessels होती है, digital vessels, वो calcification पे ज्यादा effect नहीं होता उनका. That's why we can take toe pressures. ठीक है. अच्छा, डॉपलर का मेंशन किया आपने. डॉपलर और डुप्लेक्स में क्या फर्क है?
So Doppler, it only tells about the direction. It only tells about the moving, that the blood is moving, so it
Okay.
detects that. And the duplex ultrasound, it can also tell about the anatomy of the vessel and its the turbulence of the blood flow.
Okay. So duplex basically combines the B mode ultrasound along with Doppler.
Yes, sir.
अच्छा, डॉपलर की भी आपने रिपोर्ट पढ़ी हो तो उसमें लिखा होता है मोनोफेजिक फ्लो, बाइफेजिक फ्लो, ट्राइफेजिक फ्लो. हैव यू एनी आइडिया अबाउट दीस थिंग्स?
So biphasic, so normally there are three phases. So if there is some there is partial obstruction, then it becomes biphasic because there is loss of that diastolic vessel compliance, and if it's a complete obstruction, then it becomes monophasic.
Okay. It basically shows the diameter reduction of the artery. अगर 20% से 50% के दरमियान स्टीनोसिस है तो फ्लो बाइफेजिक हो जाएगा, और अगर स्टीनोसिस 50% से ऊपर हो जाए टिल 99% तो वो मोनोफेजिक हो जाएगा. अच्छा, आपके पेशेंट में, your patient was having 67-year age and the main reason was atherosclerosis. Can you mention some causes of peripheral vascular disease in young patients? Let's say आपका patient 35 years का हो या 30 years का हो
Young patients,
और वो आपके पास इस तरह की symptoms के साथ आए young patients में. Some causes of peripheral vascular disease in young patient.
So it could be Burgess disease or thrombolytitis obliterative.
Okay.
Yes, sir. And
Any other
or
reason?
other,
Disorders like
or other forms of
fibromuscular
arthritis or
dysplasias.
disorders like cystic CMD or FMD. Sorry, more common in females. It could be renal.
If a young athlete comes to you with peripheral vascular symptoms like this, just like in your patient,
Yes, sir.
do you know about popliteal artery entrapment syndrome?
Yes, sir. So the popliteal artery entrapment syndrome is when the artery is entrapped between the gastrocnemius.
Okay, that's fine.
When on dorsiflexion, the pulse disappears.
So Berger disease, popliteal artery entrapment syndrome, cystic adventitial disease, connective tissue disorders, all these are causes of peripheral vascular disease in young patient.
Yes, sir.
अच्छा, आपने अपने पेशेंट की पीडल पल्सेस एग्जामिन की, एंटीरियर टिबियल पोस्टीरियर टिबियल दोनों में से एक पल्स नहीं आ रही. लेट्स से राइट साइड पे एंटीरियर टिबियल पल्स डॉर्सल स्पीडस नहीं आ रही और पोस्टीरियर टिबियल आ रही है. सो और पेशेंट के सिम्टम्स इंटरमिटेंट क्लॉडिकेशन की नहीं है, नॉर्मल पेशेंट है. इज दिस गॉट सम सिग्निफिकेंस?
So only the anterior tibial is not.
Let's say for example anterior tibial is not palpable या posterior tibial is not palpable. Pedal pulses दोनों में से एक नहीं आ रही.
Right, sir. So So it should be significant because you palpable.
कुछ परसेंटेज ऑफ पेशेंट्स में पीडल पल्सेस में दोनों में एक एब्सेंट होती है और उनको सिम्टम्स नहीं होते, तो इसकी सिग्निफिकेंस क्लिनिकली नहीं होती अनलेस अदरवाइज द पेशेंट इज सिम्टोमेटिक.
Right. Sir.
ठीक है, ठीक है. Can you name some classification system for peripheral vascular disease? Do you know about Fontaine classification?
Yes, so the Fontaine's classification, it includes 5 grades. Number
Okay.
1, asymptomatic. 2 is intermittent claudication. Then again, it's divided into 2A and 2B. 2A being when the claudication distance is more than 200, and when it's less than 200 meters, it is 2B. Then grade 3 is rest pain, and 4 is pre-gangrenous changes, and 5 is gangrene. Some say that it's 4. There are 4 parts, and some say 5.
Okay.
In this 2A and 2B, that's what
Yes.
you mentioned something about the distance.
Yes,
In
sir.
actual Fontaine classification, there is no mention about the distance. 2A is non-disabling intermittent claudication, and 2B is disabling intermittent claudication.
Right.
I don't know whether that's a vascular is here, so
Sir.
I don't know what is his take on this. This is my understanding that in Fontaine there is no mention of distance.
सर जो अपडेटेड फोंटेन क्लासिफिकेशन है उसमें सर 4 ग्रेड्स है. 1 इज एसिम्प्टोमेटिक, 2 इज इंटरमिटेंट क्लॉडिकेशन. इसमें उन्होंने मजीद क्लासिफिकेशन नहीं की, उन्होंने कहा कि 2 इज इंटरमिटेंट क्लॉडिकेशन, 3 इज रेस्ट पेन, 4 इज टिश्यू लॉस गैंग्रीन.
Yes.
और जो दूसरी क्लासिफिकेशन है वो रदरफोर्ड क्लासिफिकेशन. सर वो रदरफोर्ड है. दैट्स रदरफोर्ड सर.
नहीं,
सर
इसमें Fontaine में भी जो है that is disabling, not disabling.
क्लासिफिकेशन.
This
Sir.
I am talking
Sir.
about a very recent paper. This is about the guidelines.
Right.
ओके सर.
Rutherford
Sir.
में उसमें भी
सर इसमें 2 है. दूसरा फिर रदरफोर्ड सर उसमें फिर माइल्ड, मॉडरेट, सिवियर है.
Yes, and that also includes the rest pain and the minor tissue loss and the major tissue loss.
जी सर, मैं यही कह रहा था सर कि जो अपडेटेड फोंटेन है उसमें 4 ग्रेड्स है, जबकि रदरफोर्ड में फिर 6 ग्रेड्स है. उसमें फिर एसिम्प्टोमेटिक, माइल्ड 1, मॉडरेट 2, सिवियर 3 क्लॉडिकेशन. फिर 4, 5 में इस्केमिक रेस्ट पेन, 5, 6 में माइनर टिश्यू लॉस और मेजर टिश्यू लॉस है. तो फोंटेन क्लासिफिकेशन इज सिंपल. और अगर हम इसको इस तरह सिंपली याद रखे कि एसिम्प्टोमेटिक, इंटरमिटेंट क्लॉडिकेशन, रेस्ट पेन एंड टिश्यू लॉस, तो ये आसान होगा. बाकी रदरफोर्ड है लेकिन वो आपको बिट कंफ्यूज करेगा, कॉम्प्लिकेट करेगा. सर
2A में Fontaine में it's not disabling and 2B is disabling.
ओके
In इसको यह claudication but it carries on.
एग्रीड सर. एग्रीड सर.
अच्छा Zareen, can I make 1 or 2? अब ट्रीटमेंट डिस्कस नहीं हुई.
Sure, sir. Sure, sir.
मैं एक्चुअली थोड़ा सा ऑफ एंड ऑन दरमियान में उठता रहा हूँ. दैट इज व्हाई आई वाज म्यूटेड. घर में थोड़ा सा काम हो रहा था. ये इनकी हिस्ट्री में कोई रेनॉल्ड्स का हिस्ट्री थी?
Yes, sir. I asked about the pain aggravation on cold or any change on exposure to cold or warm.
तो कोई नहीं है रेनॉल्ड्स की फिनोमिना की कोई हिस्ट्री नहीं थी.
Yes, sir.
Neither feet nor hands.
No, sir.
Okay. And you mentioned in I think on the left side you said saphenofemoral artery level. I thought you meant superficial femoral artery level.
No, this superficial femoral artery.
Okay. Even if you ligate superficial femoral artery,
Yes, sir.
I don't think anything untoward happens. Sometimes in firearm injury, stab wounds, there is injury to the superficial femoral artery. You never attempt to repair it. Dr. Saab, क्या ख्याल है आपका?
So because of the cold,
sir,
if it is possible, yes.
Sir,
but,
you are
otherwise, superficial femoral artery की complete clotting से भी डिस्टल तो कोई प्रॉब्लम होना नहीं चाहिए unless patient is very old or atherosclerosis बाकी arteries की हुई हो. What do you think?
सर इसमें दो चीजें हैं. एक सर इंग्वाइनल लिगामेंट के साथ ही कॉमन फेमोरल आर्टरी को 2 to 3 सेंटीमीटर नीचे जाके सुपरफिशियल फेमोरल आर्टरी और प्रोफंडा फेमोरस आर्टरी में डिवाइड होती है. सो यू आर वेरी राइट सर कि लेग की यहाँ की सप्लाई दो आर्टरी से है, प्रोफंडा फेमोरस से और सुपरफिशियल फेमोरस से है. Although it's a major artery, अगर ट्रॉमा हो, the patient is not in
Actually,
shock,
जो
extremes में ना
PTL है,
हो, तो
that is
उसको
the
रिपेयर करना चाहिए सर.
profundus.
It should be repaired sir, but if the patient is in shock and as a damage control surgery आप इसको ligate कर सकते हैं क्योंकि profunda femoris artery will take over the circulation. But in this case, when you ligate the superficial femoral artery, especially in trauma and young patient, we have to closely observe the patient because
Yes.
limb loss की chances ज़्यादा है. So
Okay.
profunda femoris can take over the circulation of lower limb, but as is a major artery of the lower limb, it should be repaired, sir.
अच्छा, एक और चीज है, मैं सॉरी दरम्यान में थोड़ा उठ गया था. कैरोटिड आर्टरी ब्रूई आपने
जी
सुनी
सर,
थी इसमें?
please.
Yes, sir. I checked the bruit over the peripheral and central vessel
नहीं
arteries.
थी इसमें. कोई ऐसा कोई टेस्ट आपने एब्डोमिनल एओर्टिक एन्युरिज्म के लिए किया?
Sir, I checked for bruit. And
Sorry, you checked what?
the bruit, and on palpation there was no mass or pulsatile.
No, I think a patient who is hypertensive
Yes, sir.
and who has got peripheral arterial disease, 60 years old है कि 50 है, smoker, तो abdominal aortic aneurysm को तो exclude करना पड़ेगा, और उसको exclude करने के लिए you have to make a certain examination technique for the aorta. thin person था ये, और दूसरा ये कि आप telltale sign femoral artery का आप diameter भी देख सकते हैं, उसमें तो नहीं था कुछ. Another question तो नहीं, एक comment था कि ये patient तो thin था. Suppose the patient is diabetic as well and there is edema on the foot, उसमें तो ankle brachial index या ulcers हैं उसके ऊपर, उसमें क्या करेंगे ankle brachial index की बजाय?
So we can use the peroneal artery as well.
I don't know, vascular surgeon is sitting, I'm not a vascular surgeon.
Sir can tell better.
Toe brachial index नहीं हो सकती?
The toe पे हो सकती है.
Toe brachial index.
तो
जरीन साहब ने एक सवाल पूछा कि any procedure to decrease walking impairment or to increase claudication distance, कोई ऐसी फार्माकोथेरेपी है?
sir, pharmacotherapy में sir there is sir we can use aspirin and clopidogrel as a preventive measure, and also xylostazole, which is Pletol के नाम से जो आती है sir, वो भी use होती है. And smoking cessation also has a big role. Has
Yes.
statins for the cardiac, and
Statins.
beta blockers should be avoided.
कोई specifically antihypertensive है जो verapamil जो है वो increase करता है walking distance?
Right, sir.
तो भी treatment तो discuss नहीं हुई ना?
नहीं sir.
Sir, I would like to add a few points and ask a few questions if you allow me, sir.
Yes, please.
Sure.
जी जी डॉक्टर मारिया, आप आपके पेशेंट की तरफ आते हैं, तो किस कैटेगरी फाउंटेन क्लासिफिकेशन में आप अपने पेशेंट को प्लेस करेंगे? Because your patient has got rest pain and tissue loss.
Sir, tissue loss भी हो गया तो grade 4 हो जाएगा.
Grade 4 हो जाएगा. So what is the difference? What is critical limb ischemia? How will you define critical limb ischemia?
Critical limb ischemia is when the patient has rest pain or the ABPI is less than 0.5 and the Burgess angle less than 25 or 30.
Okay. In terms of prognosis, in terms of outcome, आप उसको कैसे define करेंगे? अगर आप critical limb ischemia को treat नहीं करेंगे तो क्या हो जाएगा?
So it will progress to limb loss.
It will progress to limb loss and amputation. Chronic limb ischemia by definition और acute limb ischemia में time duration का कितना फर्क है?
So acute is sudden and it within within 6 hours.
ठीक है.
And the chronic one is usually progressive over months or years.
But if you define it, chronic limb ischemia अगर symptoms 2 weeks से ज़्यादा के हैं तो फिर उसको आप chronic limb ischemia लेबल करेंगे. Similarly for rest pain, अगर किसी patient को rest pain 1 to 2 3 days का है तो वो नहीं, by definition it's the rest pain more than 2 weeks. आपके पेशेंट में अब आगे कैसे प्रोसीड करेंगे? बेसलाइन टेस्ट्स कौन से करवाएंगे और डॉपलर कराएंगे नहीं कराएंगे, उसके फाइंडिंग्स के बारे में कमेंट करें.
So baseline investigations would include the blood tests, which are the same as full blood count to exclude anemia, or RBS for diabetes, the renal profile, or we also check for we also do the ECG and chest X-ray. An echocardiogram is done for the cardiac condition. We can also add on the pulmonary function test if some lung problem or an arterial blood gases can be done. So the imaging regarding a Doppler ultrasound that is already done, and other than that, ultrasound examination as well as we.
आपके पेशेंट में एंजियोग्राफी इंडिकेटेड है कि नहीं है, और अगर इंडिकेटेड है तो आप कौन सी एंजियोग्राफी कराएंगे?
Should go for CT angiogram first, and if we are planning an intervention, then an invasive angiogram can be done.
Why CT angiography first? Why not invasive angiography first? Any reasons?
So because it is less invasive, and
it's
it
less
would
invasive.
The site of the occlusion as well as extent of the disease process as well as other sites if present.
Any special precaution will you take before proceeding to CT angiography?
The allergy to contrast agent should be excluded. The renal function test should be normal.
Okay, two things are important. Contrast-induced nephropathy, so the patient should have normal urea creatinine and renal function, and the history of contrast allergy should be excluded. And if it's better to rehydrate the patient first.
Yes, sir, right.
MR angiography कराएंगे नहीं कराएंगे?
सर करा सकते हैं.
करा सकते हैं.
If the CT angiogram is contraindicated, we can go for that.
ठीक है. ओके. आपके पेशेंट में क्रिटिकल लिम्ब इस्कीमिया है, तो इज ही अ कैंडिडेट फॉर एनी इंटरवेंशन और यू शुड गिव हर मेडिकल ट्रीटमेंट?
So he is a candidate for intervention because he's having this occlusion probably at the level of SFA.
Okay.
So some sort of intervention.
So coming the other way around, in peripheral vascular disease, किस कैटेगरी में आप पेशेंट को बेस्ट मेडिकल थेरेपी देंगे और कौन सी कैंडिडेट्स होंगे इंटरवेंशन के लिए?
Sir, if it's not breast pain, sir, till the intermittent claudication, we give medical therapy. And when the patient has developed breast pain or develops some sort of pre-gangrenous or gangrenous changes, then it's indicated to go for an intervention.
ठीक है. So intermittent claudication वाले पेशेंट को आप बेस्ट मेडिकल थेरेपी पे रखेंगे और ऑब्जर्व करेंगे कि उनकी इंटरमिटेंट क्लॉडिकेशन इंप्रूव हो रही है, वर्स हो रही है. और अगर इनको क्रिटिकल लिम्ब इस्कीमिया which means rest pain and tissue loss, तो they are candidates for intervention. That may be endovascular, that may be open. अच्छा, मेडिकल थेरेपी, what are the different options? क्या क्या कौन से मेडिकल थेरेपी में क्या क्या इंक्लूडेड है जो आप देंगे अपने पेशेंट को?
In the medical management, we'll start with the risk factor modification. Like patient has hypertension, so we should control that. If he's smoking, so encouraged to quit smoking, or the smoking cessation drugs can be used. So we can control the diabetes, hyperlipidemia. We can give statins. If obese, we can encourage to do for weight loss. And other than that, we can modify the lifestyle, including the exercise program. Usually, it is recommended that 2 hours per week for around 3 months. It improves the claudication distance, and we should give aspirin or clopidogrel 75 mg per day. Even one can
Okay.
be used as a preventive measure. And
Any other drug which you want to mention?
the silostazole, we have
Okay.
that for it
By which
for
name it's available in the market? Silestazole.
ketol, by the name of ketol 100 mg.
Okay. And what's its mechanism of action in peripheral vascular disease?
Inhibited. So it dilates the vessels.
Okay, it's a peripheral vascular dilator. It's a smooth muscle relaxant, and it has also got some antiplatelet effects.
Right.
So, in which dose would you start Pletal or silestazole to your patient?
100 mg BD.
100 mg BD is the maximum dose. You start with 50 mg OD, then gradually increasing it to 50 mg BD, and then the full dose 100 mg BD.
Okay, sir.
So you have started your patient on best medical therapy. He's an intermittent claudicant, and his intermittent claudication is not improving. What will you do then? After 2 months of best medical therapy, the patient reported back that his intermittent claudication is not improving.
Then we can work him up for the intervention, which could be through transluminal angioplasty, or can go for stenting. So if it is involving a short segment, the stenosis, and if it's a long segment, then can offer a bypass in the form of operative intervention.
Okay. So before any intervention, would you like to do a CT angiography?
Before intervention and invasive, yes, sir, we can do a CT angiogram.
It's mandatory to go for angiography, CT angiography, MR angiography, or if not available, conventional angiography before performing any bypass or any intervention procedure. And
Yes.
what's the important points which we will see in angiography before proceeding to any bypass? आप क्या देखना चाहेंगे जिससे आपने ये डिसीजन लेना है कि मैंने मरीज का peripheral bypass करना है या intervention procedure करना है कोई?
So we look at the site of the obstruction or stenosis.
Okay, you will confirm the site of obstruction and stenosis.
The segment, the length of the segment that is involved,
Okay.
and then the proximal status of the vessel, as well as the distal runoff.
Okay. So what's the concept of distal runoff?
So the distal vessel should be patent if we are to go for a bypass.
Okay. So if there is a proximal obstruction, why would the distal vessels would be patent? कैसे patent होंगी?
So because there is co-lateralization.
There is collateral circulation. Okay, good. और distal circulations patent नहीं होगी, distal runoff patent नहीं होगा, तो फिर उस patient में bypass successful होगा या नहीं?
No, sir.
क्यों?
Because they would not be there would be distal obstruction then. So.
Okay, distal vessels will be clogged with thrombosis or atheromas. तो उसको अगर आप bypass दे भी दे तो वो चलेगा नहीं, ठीक है? अच्छा, what are the different endovascular options?
Transluminal angioplasty with stent.
Angioplasty plus minus stenting. Okay.
Balloon dilation.
Balloon dilatation. Angioplasty basically means balloon dilatation. And stenting, if the angioplasty is successful and if you think that it will retain, then there is no need of stenting. Otherwise, you can stent the patient. And can you name a few peripheral bypass procedures, surgical procedures?
Yes, sir, various bypass procedures are there. Starting from the aortoiliac disease, we usually go for aortobifemoral bypass if the patient, if the patient is unfit, we go for axillofemoral bypass, and which can be or bilateral. Then if there is iliac occlusion, we usually go for iliofemoral bypass, or can go for femoral crossover graft. Then if there is femoropopliteal, if there is in my case, like it's a saphenofemoral artery occlusion, then we can go for femoropopliteal bypass. And if there is distal occlusion, if there is popliteal involvement or distal, so we can go for a femorodistal bypass.
Okay, what different type of conduit you can use for bypass? Name a few.
So the conduit usually we can use the long saphenous vein, or
Okay.
they can be synthetic materials as well, like PTFE
You
or
have got a
Dacron.
patient whose long saphenous vein has been used in cardiac bypass. So is there any other site for harvesting vein in the body?
And so the other superficial veins can be utilized, the
Okay.
arm vein
Arm
or
veins can be utilized. So in the order of priority, long saphenous vein from one leg, from the other, short saphenous vein and arm legs can be used. Even the superficial femoral vein can also be used.
right.
Can you name some prosthetic material?
So PTFE,
PTFE.
polytetrafluoroethylene,
Okay.
and Dacron.
Dacron. If you are given choice, would you prefer an autogenous vein or a prosthetic graft?
So in the distal bypasses, usually autogenous are used,
Okay. Any
and
specific reason?
if it's usually for celiac disease, usually Dacron material is
Okay.
used.
Autogenous veins, autogenous tissue की patency ज़्यादा होती है बनिस्बत prosthetic graft की. That's why we always prefer autogenous veins. And if autogenous veins are not available, then we can go for a prosthetic graft.
Aesthetic with the Miller stuff can
Okay.
be used.
You have booked this patient for a femoropopliteal bypass. How will you counsel him before surgery?
So, so we'll counsel for the for the procedure, like it will involve like what type of incisions it will involve. It will involve the
Okay.
work of general anesthesia, and the graft will be taken from the same limb or the opposite limb.
Okay.
In the post-op recovery period, he may develop some complications, like there could be swelling of the limb, and he might need another operation. Like most commonly, the compartment syndrome occurs. So, re-surgery or fasciotomy, or
Okay. And you will counsel the patient about failure of the operation. The operation may fail and the patient may end up in amputation.
right.
So this is very important. जी सर over to Dr. Mohammad Zareen sir. आप मजीद ऐड करना चाहते हैं सर?
Thank you, Mr. Keshwar, for your excellent viva. And the same kind of pattern happens in part 2 exam, that two sets of examiners are going to examine the candidate in two different sections of the management. So almost we have come to the end of this
I need one
case.
comment, Doctor.
Yes, sir. Sure, sir.
Please. I think excellent, no problem, yes. But there was one thing, I don't know whether she'll be knowing it or not, especially for the risk of amputation in a patient who has got claudication, ulcer, maybe diabetes as well. Does she know anything about YFI classification?
YFI. No, sir.
This is to see the risk of amputation.
How about the YF? So the wound infection, the wound ischemia, foot infection
That's right.
classification. Yes,
That
sir.
is YFI classification. Okay. So if you know it well and good, if not, I think
I don't know
it's
the
about
just
time.
yes, sir.
That's all from me.
Thank you, sir.
Thank you, sir. Dr. Mari, can you know something about imputations? Is one of the management plan is a primary management for a gangrenous part of the limb, or if the surgical intervention fails, then you have to end up with amputations. So how do you do amputations, and what are the aims of your amputations?
So the aims of the amputation are to remove the dead part of the tissue, or basically the indications which include the dead, deadly, or dead loss, to make the limb suitable for a prosthesis, and to improve the quality of life. Various types of amputation.
Suppose if you have already decided about the amputation, is there any role of intraliminal intervention or bypass, in spite of the fact that the patient is a good candidate for amputation?
Yes, sir. Maybe the proximal system is involved, and we can save from a higher amputation.
So you can change the position of imputation by doing intraliminal intervention, right?
Yes, sir.
So what and how do you follow such a patient after you have done suppose a bypass procedure, femoral popliteal bypass graft, autogenous venous reverse venous graft has been taken?
Yes, sir.
So how do you follow? How do you call this patient for follow-ups?
So for the follow-up, we have to do Doppler in the follow-up to check the patency of the vessels and look for any other progression of the disease.
Obviously, you have to assess the patient's condition by taking his history and then examination, and ultimately some of the investigations if need arises. So how do you assess the patency of your graft perioperatively?
So per-operatively by the perfusion of the limb.
Yes.
And by a Doppler assessment.
Yes.
And the temperature of the foot only.
Yes. So is it always essential that after successful grafting, the pulses, they have to be within normal limits, distal pulses, they have to return back to normal?
So they should return to normal.
Okay, if suppose the pulses are not within normal limits, what other parameters are to be looked for?
See the color should be checked, or the temperature, the sensation.
Okay, any feedback from any comment from Dr. Kishwar?
Sir, as in peripheral vascular disease, the distal vascular is already diseased. So हर bypass केस में जरूरी नहीं है कि pulses आए. You basically perfuse the collaterals. Collaterals perfuse होते हैं, उसकी वजह से limb warm होना, पेन का खत्म हो जाना और wound healing improve होना. ये साइंस आपको बताएंगे कि बाईपास ग्राफ्ट सक्सेसफुल है. दूसरा सवाल सर का कि पेटेंसी कैसे कंफर्म करेंगे, तो एक आपके पास हैंड हेल्ड डॉपलर आपके पास ड्यूरिंग सर्जरी हो, उससे आप जहां से आपने डिस्टल बाईपास किए उससे डिस्टल आप चेक कर ले कि वेव फॉर्म कैसा है. और दूसरा ये कि आपके पास टेबल एंजियोग्राम अगर अवेलेबल है तो वो आपको बता देगा कि आपके बाईपास को जाना उसकी पेटेंसी कैसी है. ये दो चीजें इंपॉर्टेंट हैं. तो अदरवाइज जरूरी एक्यूट लिम्ब स्कीम में अगर आप प्रिपेयर करते तो डिस्टल पल्सेस आ जाती है मेजॉरिटी ऑफ केसेस में, क्योंकि डिस्टल वेस्कुलर डिजीज नहीं है. लेकिन जो क्रॉनिक लिम्ब स्कीम है उसमें डिजीज्ड वेस्कुलर ट्री है, उसमें जनरलाइज्ड एथेरोस्क्लेरोसिस है, डिफ्यूज डिजीज है. सो बेसिकली लिम्ब वार्म, वुंड हीलिंग और पेन का खत्म हो जाना, दिस इज इंपॉर्टेंट सर.
Excellent. Any other question by the participants? They can raise their hands or they can comment in the chat box.
Sir, there's a question by...
So basically, this segment should be conducted by Dr. Keshwar. Any questions, query, or comments by the participants? Sorry.
So there's a question by Dr. Sayed Kazim for Dr. Kishwar. How to differentiate neurogenic claudications from vascular claudications?
फर्स्ट ऑफ ऑल बाय हिस्ट्री में आपको जो वैस्कुलर क्लॉडिकेशन है उसमें टिपिकल हिस्ट्री है कि द पेन स्टार्ट्स इन द मसल ग्रुप आफ्टर वॉकिंग अ सर्टेन डिस्टेंस. इट्स नॉट प्रेजेंट ऑन द फर्स्ट स्टेप. आफ्टर वॉकिंग अ फ्यू स्टेप्स पेन विल स्टार्ट एंड इट विल सबसाइड बाय टेकिंग रेस्ट. जबकि न्यूरोजेनिक क्लॉडिकेशन का पेन स्पेसिफिक इट विल बी एसोसिएटेड विद लोअर बैक पेन रेडिएटिंग टू लोअर लिम्स, और उसमें ये कहा जाता है कि पेशेंट जब बैठता है या उसको अपनी बैक को फ्लेक्स करता है तब जाके वो पेन खत्म होता है. सिर्फ रेस्ट पे जो है ना वो पेन नहीं खत्म होता. नंबर 2 इज एग्जामिनेशन पे आपको न्यूरोजेनिक क्लॉडिकेशन में बाउंडिंग पल्सेस, लिम्ब वार्म मिलेगा, एट्रोफी उस तरह नहीं होगी. जबकि वेस्कुलर क्लॉडिकेशन में पल्सेस का एब्सेंट होना, लिम्स का कोल्ड होना और बाकी जो इस्कीमिया की साइंस है वो मिलेंगे आपको. तो बेसिकली हिस्ट्री और क्लिनिकल एग्जामिनेशन है, और फिर आप इन्वेस्टिगेशंस की तरफ आते हैं तो आपको नॉर्मल आर्टेरियल डॉप्लर मिलेगा वेस्कुलर में, जबकि न्यूरोजेनिक में आपको न्यूरोजेनिक में, जबकि वेस्कुलर में जो है डेफिनेटली आपको डिजीज मिलेगी.
Okay, thank you, sir. So there's another question, how to determine the level of amputation? How can it be clinically assessed?
Level of amputation on examination, अगर किसी पेशेंट की popliteal pulse नहीं आ रही और limb cold है below knee, तो definitely you will go above knee amputation. किसी की popliteal pulse आ रही है, foot ischemic है, you will go for below knee amputation. Muscle bulk, muscle की जो है ना उसकी vascularity देखनी है आपने, और पर ऑप भी आपको असेसमेंट हो जाती है जब आप बिलोनी एम्पुटेशन कर रहे होते हैं या अबाउनी एम्पुटेशन कर रहे होते हैं, तो मसल की वैस्कुलरिटी कि कितना ब्लीड कर रहा है, तो प्री ऑप भी आप असेस जी.
Thank you, sir. Sir, and Dr. Saeed Amir is asking how to measure toe pressure. We talked about toe pressure being the most accurate, so how to measure that?
Basically it's mentioned in the books and the literature, but it's too difficult in our setup, क्योंकि इसके लिए आपको स्पेशल कफ चाहिए होते, छोटे स्मॉल साइज के कफ जो कि लेजर डॉपलर से या इससे वो फ्लो को मेजर करते हैं. डिजिटल आर्टरी में आप डॉपलर से तो फ्लो मेजर करना बहुत मुश्किल है, तो बेसिकली इसके लिए आपको लेजर डॉपलर प्रोब चाहिए होते हैं जो कि रूटीन में हमारे पास अवेलेबल नहीं होते. इट्स ओनली टू मेंशन कि आपको पता होना चाहिए कि अगर एंकल ब्रेकियल प्रेशर ABPI 0.3 से ऊपर है तो आपके पास नेक्स्ट ऑप्शन क्या है, दैट इज टो ब्रेकियल प्रेशर इंडेक्स. लेकिन प्रैक्टिकली हम न कर रहे ना हमने देखे.
Okay, thank you, sir. So Dr. Mariam.
Sayyid Kazim was asking about different types of claudication. Okay, the osteoarthritis pain is right from the beginning. It's present all the time. And the spinal stenosis pain will be relieved, as Kishore has already said, it will be relieved by bending forwards or window shopping. And the claudication, vascular claudication will be initiated only after walking for a certain distance and will be relieved by taking rest. So these are the differentiating points on history.
Thank you, sir. So Dr. Mariam Munir is asking, we talked about CTA, that it will tell us about the length of segment which is involved. So how to decide different intervention procedure according to the length of segment being involved?
इसमें आपने इंटरवेंशन आपके पास दो तरीकों से है, एक तो एंडोवास्कुलर है, एंजियोप्लास्टी प्लस माइनस स्टेंटिंग, और दूसरा ओपन बाईपास प्रोसीजर है. तो दिस इज अ वेरी इंपॉर्टेंट क्वेश्चन, एंड इसमें ये है ना कि इसके लिए लिटरेचर में है टास्क क्लासिफिकेशन, ट्रांस अटलांटिक सोसाइटियल क्लासिफिकेशन, उस पर डिसीजन होता है कि कितनी लेंथ है, और इसके लिए प्रॉपर गाइडलाइंस है. द क्लासिफिकेशन इज ट्रांस अटलांटिक इंटर सोसाइटी कंसेंसस गाइडलाइंस, जो उसमें 4 कैटेगरीज उन्होंने दी होती है, टाइप ए, टाइप बी, टाइप सी एंड टाइप डी लीजन्स. तो उस लीजन्स के हिसाब से जो टाइप ए टाइप बी की लीजन्स है उसमें वो प्रीडोमिनेंटली एंडोवास्कुलर प्रोसीजर्स, एंड टाइप सी और डी लीजन्स में प्रीडोमिनेंटली ओपन प्रोसीजर्स. सो इसमें आयोटा, आइलियक्स, फेमरल, पॉप्लिटियल एंड टिबियल वेसल्स के लिए डिफरेंट लेंथ्स है. सिंपली मैं आपको बता दूं कि लेट्स से अगर एसएफए की डिजीज है, सुपरफिशियल फेमरल आर्टरी की डिजीज है, तो उसमें अगर 15 सेंटीमीटर तक लेंथ इन्वॉल्व है उसको आप एंडोवास्कुलरली कर सकते हैं. बियॉन्ड 15 सेंटीमीटर यू नीड अ फेमरोपॉप्लिटियल बाईपास. Below 15 centimeter आप endovascular approach is possible, definitely in specialized centers. इस तरह आइलिक्स में उन्होंने 10 सेंटीमीटर का बताया हुआ है कि 10 सेंटीमीटर से नीचे नीचे आप इंटरवेंट कर सकते हैं एंडोवास्कुलरली, वरना आपको बाईपास की जरूरत पड़ती है. So it's properly mentioned in task classification, transatlantic inter-society consensus guidelines for approach either endovascularly or either open surgery.
Okay, thank you very much, sir. Very nicely explained. Sir, there's also a question by Dr. Wahid that in case of trauma, if there is a contaminated wound with femoral artery being damaged, so can we repair the femoral artery in a contaminated wound?
ट्रामा की तकरीबन हर केस में वुंड कंटामिनेटेड ही होता है, अगर वो गन शॉट हो, रोड ट्रैफिक एक्सीडेंट हो, जो भी हो. एज इट्स अ मेजर आर्टरी, सो यू हैव टू रिपेयर इट आफ्टर प्रॉपर डिब्राइडमेंट, प्रॉपर वुंड वॉश. और जो ऑटोजेनस कंड्यूव हमारे पास है जैसे सुपरफिशियल फेमरल वेन्स हैं, तो उनका रिजल्ट अच्छा होता है. तो आफ्टर प्रॉपर डिब्राइडमेंट, प्रॉपर डिब्राइडमेंट ऑफ द वेसल एज वेल, जो डिवेटलाइज्ड आर्टरी है वो भी आपने काटनी है और फिर उसको रिपेयर करना है रिवर्स ग्राफ्ट में. और दूसरा अच्छा ये है कि आप ग्राफ्ट को अगर फेशन कर सके लेटरली या मीडियली थ्रू वेस्कुलराइज्ड मसल्स उसमें बरी कर दे, तो आप कंटामिनेटेड एरिया से उसको एक्सक्लूड कर देते हैं. बट यस, यू हैव टू रिपेयर इट बिकॉज़ इट्स अ मेजर आर्टरी, और आफ्टर प्रॉपर डिब्राइडमेंट, प्रॉपर कवर.
Sorry to interrupt you, sir, but that what you're telling is what what a vascular surgeon can do. What should a general surgeon, like, because they're the ones who are dealing trauma in the first hand case, so what should they do while they are able to transfer the patient to a vascular surgeon? You know, time buying procedure.
That's called damage control vascular surgery, and you can do a temporary vascular shunt. टेम्पररी वैस्कुलर शंट आप किसी भी साइज का ट्यूब लेके, स्मॉल साइज एनजी ट्यूब, स्मॉल साइज ड्रिप सेट प्रॉक्सिमल आर्टरी में, डिस्टल आर्टरी में डाल के उसको टाई लगा दे ताकि आप सर्कुलेशन को रिस्टोर कर सके, एंड देन यू कैन डेफिनेटली ट्रांसफर टू अ प्रॉपर स्पेशलाइज्ड यूनिट. लेकिन मेरे ख्याल है कि वैस्कुलर रिपेयर इज नॉट दैट मच स्पेशलाइज्ड वर्क. Every general surgeon should know how to repair a main femoral artery, brachial artery. Reverse long saphenous graft is not a difficult task. एक दो दफा देखने की बात है, and it's a simple procedure. But yes, if you are in periphery, you don't have expertise, and you don't know how to do it, then a simple temporary vascular shunt is the best option. किसी भी साइज का ट्यूब लेके proximal distal डाल के उसको टाई कर दे, और उसको इतना टाइट ना करे कि उसकी सर्कुलेशन रुक जाए. Distal vasculature में it's better to flush it with heparinized saline. Yes. Take some 1 cc heparin, dilute it in 200 to 300 normal saline, and put a small size NG tube in the distal vessel and flush it with heparinized saline. Then put a temporary vascular shunt and inform the receiving facility.
Thank you, sir. And sir, Dr. Saad is asking, if a patient has multiple ulcers on the leg, then how are we supposed to measure ABPI?
ABPI मेजरमेंट के लिए आपको डॉपलर प्रोब चाहिए. डॉपलर प्रोब तो आप अगर लेट्स से डॉर्सिलस पीडियस आर्टरी का जो एरिया है या एंटीरियर टिबियल का है, पोस्टीरियर टिबियल का है, वहां पे आप डॉपलर प्रोब तो रख सकते हैं. तो अगर फुट पे अल्सर्स है, आपने तो जो कफ बांधना है वो एंकल पे बांधना है, जस्ट अबाउट द मीडियल मेलियोलस. वहां पे अल्सर है तो डेफिनेटली इट्स डिफिकल्ट, लेकिन अगर वहां अल्सर नहीं है तो आपने डॉपलर प्रोब ही रखना है, उससे तो आप मेजर कर सकते हैं.
Okay, thank you, sir. And sir, what about graft failure in proximal bypass comparison with distal bypass surgery? Graft failure.
Definitely proximal में results अच्छे हैं, distal में results इतने अच्छे नहीं हैं, and it all depends on your decision कि what about कि distal runoff कैसा है, distal disease calcified है कि नहीं है, patient के mobility status कैसा है. तो definitely your proper case selection is very important for a bypass procedure. और proximal में definitely vessel का डाया अच्छा है, आप जो है ना उसमें results अच्छे हैं compared to below-knee bypasses.
Okay, thank you, sir. And sir, how about?
It's not only it's not the only distal runoff. It's all the run in is also important. So that's why Dr. Kish was talking about the importance of CT angiograms.
Okay. Thank you, sir.
You basically need a proper inflow, a proper outflow, and a proper conduit. 3 things are very important in a bypass procedure. अगर इनफ्लो अच्छा नहीं है, जैसे आप फेमोरल से इनफ्लो ले आ रहे हैं लेकिन आइलिक लेवल पे या डिस्टल आयोटा लेवल पे डिजीज है, तो फिर वो इनफ्लो डेफिनेटली अच्छा नहीं है, बाईपास अच्छा नहीं चलेगा. यू शुड गो फॉर मोर प्रॉक्सिमल इनफ्लो. कंड्यूट अच्छा होना चाहिए और डिस्टल रन ऑफ अच्छा होना चाहिए. 3 कंपोनेंट्स आर वेरी इंपॉर्टेंट इन द बाईपास प्रोसीजर.
Thank you, sir. And so Dr. Ahmed Shahzad is asking, what about reperfusion injury, and what are the guidelines in which we should choose between a bypass or an amputation in order of risk of reperfusion injury?
Again, it's different in acute and chronic limb ischemia. Chronic limb ischemia में तो बहुत कम चांसेस है क्योंकि ऑलरेडी कुछ ना कुछ सर्कुलेशन चल रही है, कोलेटरल्स है, और चांसेस आर वेरी लेस. लेकिन अगर आपको ऑन टेबल पता चल गया कि आपने बाईपास किया और काफ बिकम टेंस एंड टेंडर, तो आप उसी टाइम प्रोफाइलेक्टिक फेशियोटमी कर दें. द चांसेस आर मोर इन एक्यूट लिम्ब इस्कीमिया या ट्रॉमा में, और उसमें जितना टाइम ज़्यादा गुजरा होता है, पेशेंट आपके पास लेट प्रेजेंट करता है, प्रॉक्सिमल डिजीज होती है, तो उसमें कंपार्टमेंट सिंड्रोम के चांसेस बहुत ज़्यादा हैं. द डायग्नोसिस इज क्लिनिकल. यू चेक फॉर द काफ, यू चेक फॉर द थाई. काफ में ज़्यादा चांसेस है. अगर काफ टेंस है क्लिनिकली, देन यू शुड गो फॉर फेशियोटमी. अदरवाइज तो कंपार्टमेंट प्रेशर मेजर करने की बातें हैं, लेकिन आपके पास स्पेशलाइज्ड इक्विपमेंट्स वो है तो होता नहीं है ट्रॉमा में. तो देयरफॉर अगर आपका पेशेंट एक्यूट लिम्ब इस्कीमिया का है या ट्रॉमा का है, उसने लेट प्रेजेंट किया है, आप लेट रिवेस्कुलराइज कर रहे हैं, देन यू शुड एड अ प्रोफाइलेक्टिक 4 कंपार्टमेंट लेग फेशियोटमी टू योर सर्जरी. और किस कंडीशन में नहीं करना? अगर आपको लगे कि फ्रैंक गैंग्रीन है, स्किन पे इस्केमिक चेंजेस आ चुके हैं, एंकल इज स्टिफ, तो उस कंडीशन में आपने रिपरफ्यूज नहीं करना, एम्बोलेक्टमी नहीं करनी. यू शुड गो स्ट्रेट फॉर एम्पुटेशन एंड काउंसिल द पेशेंट, क्योंकि उसमें फिर आप रिपरफ्यूजन इंजरी के चांसेस बढ़ा देते हैं. एंड अबाउट मॉनिटरिंग, डेफिनेटली अच्छा यूरिन आउटपुट होना चाहिए, पेशेंट को कैथेटराइज करना चाहिए, डायूरीज करना चाहिए आपको, और एफिशियोटमी करनी चाहिए,
Thank you.
और मॉनिटर करना चाहिए यूरिया क्रिएटिनिन के लिए स्पेशली, और मायोग्लोबिन यूरिया के लिए.
Very nicely explained. Thank you very much, sir. And sir, Dr. Akil Kazmi is asking, what is the difference between an eluded and a non-eluded graft?
Sorry, can you repeat the question? Eluded and non-eluded graft?
Yes, sir. He's asking about the difference between these two.
Basically, what we have heard about is stents. There are drug-eluted stents and non-drug-eluted stents. Stents होते हैं जिसमें कुछ पे ड्रग कोटेड होते हैं. उनका फायदा ये होता है कि जो आप एंजियोप्लास्टी करते हैं फिर स्टेंट डालते हैं तो उसमें न्यू एंटिमल हाइपरप्लेजिया के चांसेस कम करने के लिए इसके ऊपर ड्रग होता है. तो दे आर बेसिकली ड्रग-eluted stents. ग्राफ्ट में तो ऐसे हमने इस तरह ड्रग इल्यूटेड ग्राफ्ट्स का तो नहीं सुना, लेकिन हेपरिन कोटेड ग्राफ्ट्स होते हैं रिस्क ऑफ थ्रोम्बोसिस कम करने के लिए.
Thank you very much, sir. I think no more questions. We're done with the question and answer session. Dr. Zain,
Thank you. Hello. Thank you very much, everybody, all of participants, hosts, Dr. Kishwar, Professor Dr. Muzaffar Saab, for your kind contribution and for your sharing of your knowledge. We will be looking forward to involve you people again and again in this academic process. Is on one side, it is an important part of our academic career. On the other hand, it is educating to us also. So we learn a lot from the participants, from our postgraduate students, and even from undergraduate students. So hope we'll continue this academic activity whenever feasible. Thank you all of you once again. See you in next session, inshallah.
Thank you, sir.
thank you so
Thank
much.
you, sir. It was a nice discussion, sir.
Thank you.
Sir.